I was a third-year medical student, doing my emergency medicine rotation at Mercy General Hospital in Portland, Oregon, or at least I was, until I switched to psychiatry 6 weeks later. You can call me Dr. Sophia Chen. During my 8 weeks in the ER, I thought I'd seen the full spectrum of human medical emergencies, overdoses, trauma cases, heart attacks, psychiatric episodes, domestic violence cases, but what I'm about to tell you about is the one patient encounter that made me question everything I thought I knew about consciousness, the soul, and what happens when we die, and ultimately changed my entire understanding of medicine forever. Mercy General Hospital is a level 1 trauma center located in downtown Portland, serving not just the city, but much of the Pacific Northwest. With over 800 beds and one of the busiest emergency departments on the West Coast, we see everything from minor cuts and bruises to the most complex trauma cases imaginable. DER alone handles approximately 400 patients per day, making it a perfect learning environment for medical students who want to see real medicine in action. As a third-year medical student, you occupy a unique position in the hospital hierarchy. You're no longer the wide-eyed first-year memorizing anatomy, but you're definitely not a resident with real responsibilities either. You're in this strange liminal space where you're expected to know enough to be helpful, but not so much that anyone trusts you with serious decisions. Mostly you observe, take patient histories, perform basic physical exams under supervision, and try desperately not to embarrass yourself in front of the attending physicians who will ultimately write your evaluation letters. My attending physician was Dr. Rebecca Martinez, a 12-year emergency medicine veteran who had built a reputation as one of the most skilled and demanding doctors in the department. Dr. Martinez was known for her photographic memory, her ability to diagnose rare conditions that other doctors missed, and her complete intolerance for lazy thinking or sloppy clinical work. Medical students either loved her or were terrified of her, depending on how well they performed under pressure. She had a way of asking exactly the right question to expose whether you really understood what you were talking about, or if you were just regurgitating textbook knowledge. I was determined to impress Dr. Martinez. I spent hours every night reading medical journals, reviewing case studies, and memorizing differential diagnoses for every condition we encountered. I wanted her recommendation letter for residency applications, but more than that, I wanted to prove to myself that I had what it took to be an emergency physician. The emergency department at Mercy General operates on controlled chaos. During my rotation, I had assisted with everything from simple lacerations and minor fractures to multi-trauma cases involving car accidents, shootings and overdoses. You develop thick skin quickly in the ER. People come in screaming, bleeding, sometimes dying, and you learn to compartmentalize your emotions, think clinically, and follow evidence-based protocols, even when your heart is breaking for the patient and their family. I had seen stroke patients whose entire personalities changed in an instant. I had watched teenagers die from drug overdoses while their parents sobbed in the waiting room. I had helped save the life of a construction worker who fell 3 stories and somehow survived with only a broken leg. ER teaches you that the human body is simultaneously incredibly fragile and remarkably resilient, often in ways that seem to defy medical logic. By my 7th week at Mercy General, I felt like I was finally hitting my stride. I could start IV lines on difficult patients. My differential diagnoses were becoming more sophisticated, and I had even correctly identified a rare presentation of appendicitis that Dr. Martinez initially missed. She had actually complimented my clinical reasoning in front of the other residents, which felt like winning the lottery. I was seriously considering applying for emergency medicine residency programs, imagining myself as an attending physician running my own trauma team. The emergency medicine rotation was supposed to teach us how to think on our feet, how to make rapid decisions with limited information, and how to manage the emotional intensity of life and death situations. It was designed to show us whether we had the temperament and skills for emergency medicine, one of the most demanding specialties in all of medicine. I thought I was acing the rotation. I thought I understood what emergency medicine was all about. That confidence, that sense of understanding the boundaries of medical science, would be completely destroyed by what happened during my very last night shift at Mercy General. The inciting incident, 8 miss 15 minutes. It was December 3rd, 2019, a cold Tuesday night in Portland. The weather was typical for early December for a rainy, windy, and miserable enough to keep most people indoors. The ER had been unusually quiet for a Tuesday evening. We'd had a few routine cases, an elderly man with chest pain that turned out to be acid reflux, a teenager with a sprained ankle from skateboarding, a woman with kidney stones, and one regular patient with chronic pain seeking medication refills. Dr. Martinez had even commented that it was one of the quietest nights she'd seen in months. I was in the break room around 11:45 p.m., reviewing chest x-rays and trying to stay awake with my third cup of coffee, when the emergency medical services radio crackled to life, with a priority alert that would change everything I thought I knew about medicine and human consciousness. Mercy General, this is Ambulance 47 en route to your location, with a priority 1 trauma. The paramedic's voice came through clearly, though I could hear the strain and urgency in his tone. The 26-year-old female, motor vehicle accident victim, found unresponsive at the scene with no detectable pulse or breathing for approximately 20 minutes. Before we achieved ROS, patient was trapped in her vehicle after a head-on collision with a tree on Highway 26. ROSC missed return of spontaneous circulation. The paramedics had managed to restart her heart, but after 20 minutes without circulation, the chances of meaningful neurological recovery were virtually zero. After just 4 to 6 minutes without oxygen, brain cells begin dying irreversibly. After 10 minutes, severe brain damage is almost certain. After 20 minutes, patients who survive are typically left in persistent vegetative states, or with such severe cognitive impairment that they require full-time care for the rest of their lives. Dr. Martinez immediately went into trauma mode. Sophia, I need you to call the trauma team, get blood bank on standby for massive transfusion protocol, and prepare Trauma Bay 1 for a critical arrival. Move fast. We'll have maybe a 5-minute window to assess neurological function before we know if we're dealing with a viable patient or someone who's technically alive but neurologically devastated. The emergency department transformed instantly from quiet routine to controlled emergency chaos. Nurses appeared from everywhere, wheeling equipment and preparing medications. The trauma surgeon, Dr. James Kim, arrived within minutes, along with an anesthesiologist and respiratory therapist. Everyone understood the gravity of what we were about to face. When the ambulance doors burst open at 12:03 a.m., what rolled into Trauma Bay 1 was a scene that would be burned into my memory forever. The patient's name was Isabella Rodriguez, a 26-year-old graduate student in environmental science at Portland State University. According to the paramedics, she had been driving home from the library when her car hit a patch of ice, skidded off Highway 26, and slammed headfirst into a massive Douglas fir tree. The impact had crushed the front of her Honda Civic like an accordion. It took the fire department nearly 45 minutes to extract Isabella from the wreckage, using hydraulic rescue tools. During that entire time, she had no detectable pulse, no spontaneous breathing, and no response to painful stimuli. The paramedics had performed CPR continuously, finally achieving return of spontaneous circulation just as they loaded her into the ambulance. When I first saw Isabella on the trauma gurney, she looked exactly like what I expected from someone who had been clinically dead for 20 minutes. Her skin was pale with a grayish tinge, her lips were still slightly blue despite the oxygen mask, and there were obvious signs of trauma. A large bruise across her forehead from the steering wheel impact, lacerations on her arms from broken glass, and what appeared to be multiple rib fractures from the seatbelt. Dr. Martinez began her primary assessment immediately. Isabella, can you hear me? Open your eyes if you can hear my voice. No response. She checked pupil reactivity, sluggish, but present. She tested basic reflexes, minimal and inconsistent. Isabella's vital signs showed a heart rate of 110, blood pressure barely maintaining at 90/60s, and oxygen saturation hovering around 88% despite supplemental oxygen. "This is exactly what we'd expect," Dr. Martinez said quietly to the team. "Severe anoxic brain injury from prolonged cardiac arrest. We'll run the full trauma workup, but neurologically, the prognosis is extremely poor." I was assigned to stay with Isabella, while the team ordered CT scans of her head, chest and abdomen, comprehensive blood work including arterial blood gas analysis, and a full toxicology screen to rule out any contributing factors. Standard protocol for major trauma with suspected brain injury. While we waited for the imaging results, I performed a detailed secondary assessment, checking for injuries that might have been missed in the initial trauma evaluation. That's when I noticed something that made absolutely no sense given Isabella's medical condition. Despite being unconscious and supposedly suffering from severe brain damage, Isabella's breathing pattern was completely normal and self-regulated. Patients with significant anoxic brain injury typically require mechanical ventilation because the brain centers that control breathing are among the first to be damaged by oxygen deprivation. But Isabella was breathing comfortably on her own, with a regular, unlabored respiratory pattern that suggested normal brainstem function. Even more puzzling, when I tested her deep tendon reflexes, they were not just present but completely normal. Her muscle tone was appropriate, not the flaccid paralysis typically seen in severe brain injury cases. And when I inadvertently dropped my stethoscope near her head, she flinched slightly at the sound, a response that indicated some level of auditory processing that shouldn't have been possible given her supposed condition. "Dr. Martinez," I called over, "could you take a look at this? Her neurological signs aren't matching what we'd expect from prolonged cardiac arrest." Dr. Martinez approached the bedside with a skeptical expression. She had seen thousands of trauma cases and wasn't easily surprised by unusual presentations. But as she performed her own neurological assessment, her expression gradually changed from skepticism to confusion to something approaching disbelief. "This doesn't make sense," she muttered, more to herself than to me. "Her reflexes are intact, her breathing is self-regulated, her muscle tone is normal. After 20 minutes of cardiac arrest, she should be showing signs of decorticate or decerebrate posturing, absent reflexes, irregular breathing patterns." That's when Isabella Rodriguez opened her eyes and spoke words that would haunt me for the rest of my medical career. "Excuse me, doctor," she said in a clear, strong voice, looking directly at Dr. Martinez, "but I need to tell you something very important about what I saw while I was dead." The trauma bay fell completely silent. Dr. Martinez, Dr. Kim, the nurses, the respiratory therapist, everyone stopped what they were doing and stared at Isabella in shock. Patients don't simply wake up and start talking coherently after being clinically dead for 20 minutes. "It was medically impossible, Isabella," Dr. Martinez said carefully, her voice tight with controlled amazement. "Do you know where you are?" "I'm in Mercy General Hospital, Trauma Bay 1. Isabella replied without hesitation. "You're Dr. Martinez, and that's Sophia, the medical student. I've been watching all of you work on me for the past hour." My hands started shaking. Isabella had just correctly identified not only where she was, but who we were, despite the fact that she had been unconscious since her arrival and had never been to Mercy General before in her life. "Isabella, what's the last thing you remember before the accident?" Dr. Martinez asked, her clinical composure barely masking her bewilderment. "I remember leaving the library around 11:15 p.m. I was driving on Highway 26, thinking about my thesis research on climate change impacts in the Pacific Northwest. I remember seeing the ice patches on the road and feeling the car start to skid. Then I remember the tree getting bigger and bigger in my windshield." Her memory of the accident was clear and detailed, which was remarkable enough given the severity of her head trauma. But what she said next defied every principle of neuroscience I had learned in medical school. "But that's not the important part," Isabella continued, her eyes bright and focused, despite having been clinically dead less than 2 hours earlier. While my body was trapped in the car, and while you were all working on me here, I was floating above everything, watching. I saw the firefighters cut me out of the car. I saw the paramedics working on me in the ambulance, and I've been here in this room, watching all of you trying to save my life. She paused, looking around the trauma bay with perfect clarity and recognition. Dr. Martinez, I heard you tell Sophia that my prognosis was extremely poor because of an anoxic brain injury. I heard Dr. Kim say that even if I survived, I would likely be in a persistent vegetative state. I watched Sophia notice that my reflexes were normal when they shouldn't have been. I saw everything that happened while I was unconscious. Dr. Martinez and I exchanged a look of complete disbelief. Isabella had just described, in perfect detail, private conversations that had occurred while she was clinically unconscious, events that had happened while her body showed no signs of awareness, and medical assessments that had been discussed in technical language she shouldn't have understood as a non-medical person. But the most disturbing part was yet to come. I also saw my grandmother, Isabella said, her voice becoming softer, but even more certain. She died when I was 12 years old, but she was there with me the whole time. She told me it wasn't my time yet, that I had important work to do still. She said the doctors at Mercy General were good people who would take care of me, but that I needed to come back now. The trauma bay remained in stunned silence. What we were witnessing was medically impossible, scientifically unexplainable, and fundamentally challenged everything we thought we knew about consciousness, brain function, and the boundaries between life and death. Isabella Rodriguez had been clinically dead for 20 minutes. She should have been brain dead or severely neurologically impaired. Instead, she was awake, alert, cognitively intact, and claiming to have witnessed events that occurred while she was unconscious. As a medical student trained in evidence-based medicine, I knew that what I was seeing couldn't be real. But as a human being looking into Isabella's clear, intelligent eyes, I also knew that she was telling the absolute truth about an experience that should have been impossible. Dr. Martinez's first instinct was to order every neurological test available. Within an hour, Isabella had undergone a comprehensive CT scan of her brain, an MRI with contrast, an EEG to measure brain wave activity, and extensive blood work to rule out any drugs or toxins that might explain her impossible recovery. The results were as baffling as Isabella's condition itself. Her CT scan showed minor cerebral edema, brain swelling, consistent with the trauma from her accident, but no signs of the massive cell death we would expect after 20 minutes of cardiac arrest. Her MRI was even more puzzling. It showed completely normal brain tissue, with no evidence of anoxic injury, no areas of decreased blood flow, and no structural damage that could explain her period of clinical death. Most remarkably, her EEG showed perfectly normal brain wave patterns, not the flat line of brain death, not the abnormal patterns of severe injury, but the complex, organized electrical activity of a healthy, conscious brain. "This is impossible," Dr. Martinez said quietly, as we reviewed the results together. "After 20 minutes without circulation, we should be seeing widespread neuronal death, cerebral edema, metabolic acidosis. Her brain should look like Swiss cheese on these scans." I had spent the past 2 hours researching every case report I could find about prolonged cardiac arrest and neurological recovery. The medical literature was clear. Meaningful recovery after more than 10 minutes of cardiac arrest was extremely rare. Recovery after 20 minutes with completely intact neurological function was essentially unheard of. "Dr. Martinez," I said hesitantly, "what if she's telling the truth about what she experienced? What if consciousness isn't entirely dependent on brain function the way we think it is?" Dr. Martinez looked at me with the expression she reserved for medical students who suggested something particularly naive. "Sophia, we're scientists. We deal in facts, not supernatural explanations. There has to be a medical reason for what we're seeing." But even as she said it, I could see the doubt in her eyes. Isabella's case was challenging everything we thought we knew about the relationship between brain function and consciousness. Over the next 6 hours, we consulted with neurologists, neurosurgeons, cardiologists, and even called in Dr. Patricia Williams, the chief of psychiatry, to evaluate Isabella's mental status. Every specialist who examined her reached the same conclusion. Isabella Rodriguez was neurologically intact, cognitively normal, and showing no signs of the devastating brain injury she should have sustained. Dr. Williams spent over an hour with Isabella, conducting a comprehensive psychiatric evaluation. When she emerged from Isabella's room, she looked as bewildered as the rest of us. Her cognitive function is completely normal. Dr. Williams reported memory intact, judgment appropriate, no signs of psychosis or delusional thinking. She's not making this up, and she's not having a psychiatric break. Whatever she experienced, she believes it completely. What made Isabella's case even more disturbing was the specificity of what she claimed to have witnessed while unconscious. She described in perfect detail the emergency procedures performed on her, conversations between medical staff, and even events that had occurred in other parts of the hospital while she was being treated. I watched the paramedicals his name tag, said Rodriguez, no relation to me. I watched him struggle to get the IV line started in the ambulance. Isabella told us he missed twice before he got it in my left arm. He kept saying, "Come on, Isabella, stay with us," even though I wasn't responding. We confirmed this with the paramedic team. Isabella was correct about every detail, including the paramedic's name and the difficulty with the IV placement. While you were working on me here, she continued, I also saw the elderly woman in Trauma Bay 3. She was having chest pain, and her daughter was crying because she thought her mother was having a heart attack. But I could see that it wasn't her heart. There was something wrong with her gallbladder. I felt my blood run cold. There had indeed been an elderly woman in Trauma Bay 3 with chest pain. Her daughter had been crying in the hallway, worried about a heart attack. And our diagnosis had initially focused on cardiac causes until additional testing revealed acute cholecystitis, gallbladder inflammation that can sometimes present as chest pain. But Isabella couldn't have known any of this. She had been unconscious in Trauma Bay 1, separated from Bay 3 by 2 walls and a busy corridor. There was no way she could have seen or heard what was happening with that patient. Isabella, Dr. Martinez said carefully, the woman in Trauma Bay 3, can you describe what she looked like? About 70 years old, gray hair, in a bun, wearing a blue sweater with small white flowers. She kept holding her right side, just below her ribs, and she told her daughter that the pain felt different from any heart problems she'd had before. Dr. Martinez pulled up the other patient's chart on her computer. The elderly woman, Mrs. Margaret Chen, was indeed 70 years old. When we called Trauma Bay 3 to verify, the nurse confirmed that Mrs. Chen had been wearing a blue sweater with small white flowers and had specifically mentioned that her pain felt different from previous cardiac episodes. Isabella had described, with perfect accuracy, a patient she could not possibly have seen while she was unconscious in a different room. The premonition, 24-6 minutes. But the most unsettling part of Isabella's experience was yet to come. There's something else I need to tell you, Isabella said, her expression becoming more serious. While I was away, I saw something that hasn't happened yet. I saw myself leaving the hospital tomorrow morning, but then coming back in an ambulance 3 days from now. Dr. Martinez and I exchanged glances. Isabella's medical condition was stable, her neurological function was normal, her cardiac rhythm was regular, and she was scheduled to be discharged the following day after 24 hours of observation. What did you see happening in 3 days? I asked, though part of me didn't want to hear the answer. I saw myself having a seizure at home while studying, a grand mal seizure that lasted several minutes. I saw my roommate calling 911, and I saw myself being brought back here in an ambulance. But I also saw that it would be okay. that the seizure would be related to the brain trauma from the accident, and that medication would control it. Isabella looked directly at Dr. Martinez. I know how this sounds, but everything else I've told you has been accurate. I think this is going to happen, and I think you should be prepared for it. Dr. Martinez ordered a comprehensive seizure workup, including a prolonged EEG, and additional brain imaging specifically looking for seizure foci. All the tests came back normal. There was no indication that Isabella was at risk for seizure activity. The discharge and return 26:28 minutes. Isabella was discharged the next morning as scheduled. Her neurological function remained completely normal. Her vital signs were stable, and there were no signs of complications from her accident. Dr. Martinez prescribed standard post-concussion precautions and scheduled a follow-up appointment in 1 week. I finished my emergency medicine rotation 2 days later, but I couldn't stop thinking about Isabella's case, the impossibility of her recovery, the accuracy of her observations while unconscious, and most disturbing of all, her prediction about returning to the hospital. 3 days after her discharge, I was studying in the medical library when my phone buzzed with a text message from Dr. Martinez. "You need to see this. Isabella Rodriguez just came back in by ambulance. Grand mal seizure, exactly as she predicted." I rushed to the emergency department and found Isabella in the same trauma bay where I had first met her. She was awake and alert, having recovered completely from a seizure that had lasted 4 minutes, exactly matching her prediction. The EEG now showed clear seizure activity in her temporal lobe, something that hadn't been detectable on her previous studies. "I told you this would happen," Isabella said when she saw me. "I saw it while I was dead, but I also saw that the medication would work, and that this would be the only seizure I'd have." Dr. Martinez started Isabella on anti-seizure medication. Over the following months, Isabella never had another seizure. Her neurological function remained completely normal, and she was able to return to her graduate studies without any cognitive impairment. The career-changing impact, 28:30 minutes. Isabella Rodriguez's case fundamentally changed how I viewed medicine and consciousness. Here was a patient who had been clinically dead for 20 minutes, who should have suffered irreversible brain damage, but who not only recovered completely, but also demonstrated awareness during her period of unconsciousness that challenged every principle of neuroscience I had learned. The accuracy of her observations while unconscious, her ability to describe events she couldn't possibly have witnessed, and her correct prediction of future medical events forced me to confront the possibility that consciousness might not be entirely dependent on brain function in the way medical science assumes. 6 weeks after completing my emergency medicine rotation, I changed my residency application from emergency medicine to psychiatry. I wanted to study consciousness, the relationship between mind and brain, and the experiences that patients have during near-death episodes. Dr. Martinez tried to convince me to stay with emergency medicine. "You're a natural for this specialty," she told me. "Don't let one unusual case derail your career plans." But Isabella's case had shown me that there are aspects of human experience that emergency medicine, with its focus on acute interventions and evidence-based protocols, simply cannot address. I needed to understand what had happened to Isabella, and psychiatry offered the best opportunity to study consciousness and the mysteries of human experience. During my psychiatry residency, I specialized in near-death experiences and altered states of consciousness. I've now interviewed hundreds of patients who have had similar experiences during cardiac arrest, surgery, and other medical crises. Isabella's case was unusual in its detail and accuracy, but it wasn't unique. There are more people who have experienced consciousness during clinical death than the medical community wants to acknowledge. Isabella Rodriguez taught me that consciousness is far more complex and mysterious than we understand. She showed me that the boundary between life and death, between awareness and unconsciousness, may not be as clear as medical science assumes. Most importantly, she reminded me that our patients' experiences, no matter how impossible they seem, deserve to be heard, documented, and taken seriously. I still don't have scientific explanations for what happened to Isabella, but I've learned that some of the most important aspects of human experience can't be measured by our current medical instruments or explained by our current understanding of neuroscience. Isabella's case remains the most profound and humbling experience of my medical career. It taught me that medicine is not just about treating diseases and saving lives. It's about remaining open to the mysteries of human consciousness and the possibility that there are still fundamental aspects of existence that we don't yet understand. The last time I spoke with Isabella, 2 years after her accident, she had completed her master's degree in environmental science and was beginning a PhD program. She had no lasting effects from her accident, no cognitive impairment, and no additional seizures. She was living a completely normal life. With one exception, she had become deeply interested in consciousness research and near-death experiences, volunteering as a research subject for studies investigating the relationship between brain function and awareness. That experience changed everything I thought I knew about life and death, she told me. It made me realize that consciousness is so much more than just brain activity. It's made me approach my environmental work differently too, with a sense that we're all connected in ways we don't fully understand. Isabella Rodriguez's impossible recovery and extraordinary experience during clinical death continues to challenge everything I thought I knew about medicine, consciousness, and human existence. Her case serves as a reminder that despite all our medical advances, there are still profound mysteries about life, death, and awareness that we are only beginning to explore.